Good evening to everyone and welcome to today's session. Lockdown, shockdown of India. So, another 12 days to go of this intense abstinence, social abstinence. So, I hope you're all passing through this phase courageously and taking the leverage of this time available where the nature has forced us into a holiday at home. I hope that you're all able to take this as an opportunity to prepare, to study every day, and to improve. So, Prasoon Vaidya, Arun Chauhan, Sharath, Wasim Patel, and many more who are all online. Just please drop a line to all your friends in the WhatsApp groups, Facebook groups, any groups you are part of, that the live class has started, the daily live class. Please welcome Qureshi and many more. Dr. Qureshi, you are from which part of the country, doctor? So, the beauty part of the YouTube high density video live broadcast is anywhere, anytime, affordable, accessible learning is the buzzword of the YouTube daily live classes with Dr. Murli Bharadwaj on the youtube.com/online MBBS. So, doctor, today we have 50 questions. 50 questions. I'm going to give you a very rapid fire session because 50 questions, I'll only give you 10 seconds time to quickly think and shoot your answers. Quickly think and shoot your answers. I'll give you only 10 seconds time, very fast. So the next 12 minutes, you have to finish all the 50 questions. Keep a pen and paper on the side of you while attending session so that you can be able to jot down your answer quickly. And once more, when we start the discussion, you can also repunch your answer. So that's how you are proactively participating in the discussion. Basavajit Naik and many more. Very good. Dr. Qureshi is from Rajasthan. So you also bring your other friends also to participate in this daily live online discussion across the year with Dr. Murli Bharadwaj. So, doctor, let's pick up 10 seconds time. So keep punching your answers, doctor. This is all your show, everyday show, to inspire you to prepare for the exam and image-based questions, clinical vignette-based questions um, are going to bring you the best out of you. So these are all the USMLE step one clinical vignette style-based questions in anatomy, physiology, biochemistry, microbiology, pharmacology, pathology, behavioral science. So you are going to get a very good practice of the image-based and clinical vignette-based questions. I'll be joining the discussion after you finish the rocking, sterling performance at a striking speed. You have to answer the questions extempore guessing. This is all your show. So, Ayat Vani, MedIQ, Yugender, Sara, Dhanalakshmi, and many more who are all online. You had a very rapid review of almost 50 questions within the past 15 minutes, right? So you should get the practice of quickly guessing what is that buzzword in the whole clinical presentation so that within a snap of second you should be in a position to answer. We are going to devise almost 5,000 clinical vignette based questions, image based and clinical vignette based of USMLE step 1 style from anatomy, physiology, biochemistry, microbiology, pharmacology, pathology, and behavioral science. Similarly, another 5,000 MCQs, clinical vignette based, image based, from the step 2 CK, USMLE step 2 CK, medicine, surgery, gynecology, obstetrics, pediatrics, family medicine, psychiatry, dermatology, etc., etc. So we take about 200 hours of journey together in the form of a quiz discussion. Every 50 questions are given like a set for you to answer. So like that we are going to finish in about 400 hours this 10,000 clinical vignette based and image based question bank, which is going to be used worldwide by the students in America, in India, in Philippines, in Bangladesh, every part of the world for their licensing exams. So let's make the great beginning, doctor. A 27-year-old woman presents with a nevus on her arm. She has a history that there is a change in the color of the nevus. You're able to see the nevus? And what you can appreciate in the histology, doctor, it is the histology of melanoma is what you need to remember. So now the question is, what is an indicator of, greatest indicator of poor prognosis of this patient? It is the depth. Depth within the dermis of more than 2 millimeters. So Breslow's classification, Breslow. Prognostic classification is dependent upon what, doctor? On the depth, right? So depth within the dermis of more than 2 millimeters is indicative of poor prognosis is what you need to basically remember. I'm so happy to see 30 online students. Very good, doctor. Please invite your other friends also. Asymmetrical irregular borders. That is very, very important clue to say, especially. Recently, there is a change in the color. Is another important clue to say. This is not a benign nevus. This is a malignant one, bro. That is melanoma. Now, doctor. The patients with a tumor depth less than 1.7 millimeters, they have more favorable prognosis. A, B, C, D, E of melanoma. You should not forget. Asymmetry, irregular borders. C for color variation. D, diameter more than 6 millimeters. Similarly, elevation and evolution. These are the A, B, C, D, E about melanoma is what you need to remember. A 54-year-old woman presented with a lump in her right breast. The lump is hard, non-tender, and movable. So what is that important factor that increases the risk of breast cancer, the chance of it being breast cancer in the history in this given patient? If she is having gone through menopause 2 years ago, then this hard, non-tender and movable mass, the likelihood of it being breast cancer, there is an increased risk. So, a late menopause. Now, what is her age? 54 years. 2 years before means she took 52 years before she got her menopause of breast cancer. Female, older age. Female means you may ask me a question. What is this, sir? Will male get? Yeah, why not? Male also gets breast cancer. But by being male is less risk for breast cancer, but being female, greater risk. Old age, early menarche, less than 12 years. Delayed first pregnancy, that is more than 30-year-old. If the first pregnancy happened after 30 years. And a family history of a first degree relative with the breast cancer at a very young age means you are being donated those DNA by your parents that you have a tendency towards the breast cancer. So, first degree relative with breast cancer at a young age is also considered to be a very important risk factor for the breast cancer. 11-year-old presented with the right knee pain. There are multiple ecchymosis on the upper and lower extremities. He has got a history of very easy bruising. After telling all this, you know that it is hemophilia. Hemophilia, always remember. A bleeding diathesis can occur because of what, doctor? It can occur because of the coagulation factor deficiency, or it can occur because of the platelet dysfunction. Hemarthrosis, clinically, hemarthrosis is more often a feature of coagulation disorder, factor deficiency. Whereas mucosal bleeding, petechiae, they're all more of platelet dysfunction. So this points towards the most common underlying cause of the bleeding diathesis, that would be factor 8 deficiency, leading to hemarthrosis, generally very painful, will be this hemarthrosis. A 14-year-old boy with jaundice, splenomegaly. Obviously, if splenomegaly is there, what will it lead to? What type of anemia? Splenomegaly will butcher the RBCs. It will break down the RBCs. So it will be a chronic hemolysis. So normocytic, normochromic anemia. Abnormal osmotic fragility test. Increased mean corpuscular hemoglobin concentration. So MCHC has an importance, doctor. Mean corpuscular hemoglobin concentration. Most of the anemias will lead to a decrease of MCHC. But hereditary spherocytosis is one of the few scenarios where MCHC is increased, not decreased. So, mean corpuscular hemoglobin concentration means what, doctor? How do you calculate concentration? Concentration is calculated by hemoglobin divided by the volume of the RBC. Divided by the volume. The amount of hemoglobin divided by the volume of RBC. The volume of RBC. If there is a hereditary spherocytosis, the volume of RBC decreases, denominator decreases. That is the reason the MCHC become increased. Of course, hemoglobin decreases, volume decreases, but volume decrease is more than the decrease of the hemoglobin. Whereas other type of anemias, only hemoglobin, numerator only decreases, denominator doesn't decrease, volume doesn't decrease. That is the reason MCHC will be typically decreased in all other anemias. But MCHC will be increased if it is hereditary spherocytosis, is what you need to basically remember. Very good to see 37 online students. Today we should cross half century and move forward. Right, doctor? So, MCHC. So this is the case of hereditary spherocytosis. So in hereditary sinusitis, there is a butchering of the RBC happening in the spleen that releases a lot of bilirubin. That bilirubin goes and forms pigment gallstones in the gallbladder. That's the reason. What is the rule in hereditary sinusitis, especially a child? Whenever a child is born with mass splenomegaly, generally it is hereditary sinusitis. But if you are doing splenectomy, also do cholecystectomy. That is a common rule. Because hereditary sinusitis with a significant hemolysis is often associated with the release of the bilirubin, and bilirubin excess will lead to formation of pigment gallstones in case of hereditary sinusitis is what you need to remember. So that's the reason splenectomy is considered to be the treatment of choice. Hereditary sinusitis is due to spectrin deficiency, ankyrin deficiency. RBCs are small, no central pallor because they lost their biconcave disc appearance. So no central pallor. If you are sphere in shape, no central pallor. So you do splenectomy. Quite often along with that you will also be doing cholecystectomy is what you should remember. What is the type of lymphoma which is characterized by onset in the middle age? Neoplastic cells that resemble normal germinal centers containing B lymphocytes. So this is a lymphoma which resembles like a normal germinal center. This is the classical description of follicular lymphoma. Follicular lymphoma is what you need to remember. So follicular lymphoma is associated with T1418, translocation between chromosome 14 and chromosome 18, and the BCL2 oncogene expression. Follicular lymphoma is a typically slow-growing lymphoma. It is an indolent form of non-Hodgkin's lymphoma. From where does it arise, doctor? It arises from the B lymphocytes. So this is a B-cell lymphoma. And this accounts for about 20 to 30% of all non-Hodgkin's lymphoma. Non-Hodgkin's. In India, it is diffuse large cell. Diffuse large cell B lymphocyte, B-cell lymphoma is the most common. But in America, United States of America, it is the follicular lymphoma is the most common type of non-Hodgkin's lymphoma. Unlike in India, where diffuse large B-cell lymphoma. India is diffuse. India is diffuse, India is large. Large B-cell lymphoma, diffuse large B-cell lymphoma is most common. But in America, United States of America, it is the follicular lymphoma most common. So there is a T1418 translocation. So the immunoglobulin IgH locus, which is there on chromosome 14, comes next to the BCL2 locus on the chromosome 18. And that leads to an overproduction of BCL2 protein. BCL2 protein is an anti-apoptotic factor. If there is no apoptosis, there is a development of cancer. That's what you should remember. So you can easily remember, immunoglobulin loci are on chromosome 14. So that is the reason. Production of immunoglobulin is the function of the normal B lymphocytes. That is the reason, if you look at this lymphoma's architecture, it looks like a normal germinal center which is containing the B lymphocytes is what you need to remember. A 12-year-old boy presented with a history of very dark urine. Now tell me, doctor. Hemolysis is divided into two types. Intravascular hemolysis inside the blood vessel. extravascular hemolysis which occur in the spleen, liver, etc. How do you differentiate? With the intravascular hemolysis, all that bilirubin will get filtered through the glomerulus and enter into the urine. So hemoglobinuria is the feature of intravascular hemolysis. Splenomegaly is the feature of extravascular hemolysis. Once more, doctor, I'll try to run through this very fast. Because my whole objective, let me get a bottle of water. 1 minute. Today learning is very easy. Students sit in pyjama with a t-shirt. Teacher also can sit in a pyjama with a t-shirt. And seamlessly we can discuss any number of hours together. No need of travel, no need of honking of horns, no need of pollution, no need of traffic. Even if you are sitting in Andaman Nicobar Islands or in Nicaragua or in South America or you are in Philippines, we can still meet, we can talk, we can interact, we can ask questions to each other. Thanks to the YouTube for providing a seamless live high density video broadcast. The live face-to-face classes, doctor, are like congregations. Today with all these infectious diseases, it's very difficult. Even Tirupati Balaji temple also is being closed nowadays for the visitors. So, today it is safer, easier, happier, comfortable to have a live online broadcasted class. So that is the reason, doctor, please don't forget, this couple of hours I will try to inspire you to go through some of the questions, concepts. I will give you a little ignition. But you need to go back to the online MBBS.com video library. You have an extensive video library. If you take, for example, this belongs to the topic called paroxysmal nocturnal hemoglobinuria. So there is a 20 to 25 minute video lecture on 20 points about, high yield points about PNH. Very detailed way explained and made available in the online MBBS.com video library. After participating in this discussion, you should pick up every day 4 to 5 topics. You are going to promise me. And then go back to the online MBBS.com video library and do a revision. That's all. There is no big miracle. Studying every day with a good classmate like Dr. Murali Bharadwaj for a couple of hours, getting inspired, and once more go back to the video library on the online MBBS.com. Another 3 to 4 hours you have to spend your time. 5 to 6 hours a day, oh my God, is too much of preparation. Any exam in the world you can crack, doctor. Just you need to spend 4 to 5 months of your time, not more than that also. Unnecessarily the brain gets putrefied and it's a miserable waste of your wonderful youth. 4 to 5 months, spend couple of hours discussing with me, and then the second thing is go back to the online MBBS.com video library. So doctor, now if you look at this urine sample, 7 a.m. sample, dark in color. Afternoon 3 p.m. sample is not showing hemoglobinuria. So why in the night, why only in the night there is a hemolysis in case of paroxysmal nocturnal hemoglobinuria? The reason is, fundamentally you should understand what is the problem in the PNH. Fundamentally, the problem in the PNH is there is something called PIG-A gene. If this PIG-A gene has undergone a mutation, that will lead to a problem at the level of stem cell. In the bone marrow, you have stem cells, no, doctor? Stem cells, you have a problem. RBCs are being created because of this mutation. What will happen to the RBC? A pig mutant erythrocyte, it will be lacking the GP1 anchored CD59 and CD55. Normally the CD59, CD55 which are GP1 anchored will prevent the complement mediated lysis of the RBC. If they are not there, they are called decay acceleration factors. If they are not there, then this RBC is highly vulnerable to the complement mediated overaction, and that lead to development of hemolysis and destruction. So it is what type of destruction? Complement mediated destruction of a RBC produced as a clonal stem cell defect lacking the GP1 anchored CD59-55 because of the PIG-T mutations in the hemopoietic stem cell is what you need to remember. So the problem is not just with the RBC. The problem is also there with the monocytes. The monocytes which are defectively produced, they become easily overactivated and release a lot of inflammatory mediators. That is the reason the patients who have paroxysmal nocturnal hemoglobinuria may end up with a lot of autoinflammation that lead to urticaria, arthralgia, aseptic meningitis, etc., etc. So how can you manage this? Simple. You have to use an antibody, monoclonal antibody against this complement 5. That is the only way you can prevent the complement mediated lysis of the RBCs. How can you do that? Eculizumab is considered to be the antibody to the complement 5 is what you need to remember. And why only night time? Why not morning time? Because for this complement mediated lysis of the RBCs to occur, where is it occurring? It is all occurring in the blood. In the night time, when the RBC is traveling alone, there is a villain called as complement waiting to kill it. But for that, the street light should be off. There should not be a policeman. Then only it will jump and attack RBC. So there should be a right ecosystem before this attack occurs. So what is that right ecosystem? A acidic pH. So why in the night we get acidic pH? Because when you are sleeping, your respiratory rate will come down. A low respiratory rate lead to respiratory acidosis. High respiratory rate lead to respiratory alkalosis. So a low respiratory rate leading to respiratory acidosis will make the complement go and attack the RBC. That is a point you need to appreciate. That's the reason it is typically nocturnal. So that by early morning when the patient wakes up, then you will find the presence of hemoglobinuria. Morning once more the respiratory rate normalizes when you wake up. There is no more acidic pH of the surrounding blood. And once more complement mediated lysis stops. So that's the reason it is called paroxysmal. Paroxysmal. When do paroxysms occur? Nocturnal. And what type of hemolysis? Intravascular. That is the reason what will happen? Hemoglobinuria is what you need to remember. So a untreated PNH patient, the alternate pathway become active. C3, C5 will go and attack these RBCs and lead to destruction. But if you give eculizumab, it is blocking your C5, this monoclonal antibody, and preventing the complement mediated lysis is what you need to remember. So what are the two buzzwords? PIG-A gene, CD5, CD59 and PNH. These are the buzzwords you need to remember. And one more thing, we use a ham test. Ham is pig. It is PIG-A gene and we use ham test. What is ham test? Ham test is the place where in vitro, you will typically provide an acidic milieu where you observe for the complement mediated RBC lysis. That is called ham test. So you can remember ham, you can remember the pig. You can remember eculizumab. You remember antibody to C5. You remember CD59, CD55. Their deficiency lead to C3, C5 mediated, complement mediated. Lysis is what you need to emphatically remember. Now you know everything about it, doctor. Now quickly tell me, what are the clinical manifestations of paroxysmal, nocturnal, hemoglobinuria? So you should remember that there is a hemoglobinuria. There is a prothrombotic condition. PNH is a prothrombotic state, just like nephrotic syndrome is a prothrombotic state. That lead to the hepatic vein thrombosis leading to Budd-Chiari syndrome. And paroxysmal nocturnal hemoglobinuria in the bone marrow is a stem cell defect. And that is not going to affect only the RBCs. Even it is going to affect the monocytes. Over a period of time, all the three cell lines, platelets, RBCs, WBCs. That's the reason aplastic anemia is one of the very important complications of the PNH is what you should not forget. Now let us do a little mathematics. A research group is studying thalassemia in a small community of 6,000 people. At the beginning of the year, it is determined that 10% are homozygous for thalassemia gene. That means out of 6,000, 600 are known to be homozygous for thalassemia gene. 30% of the community is heterozygous for the mutant allele. Over a course of a year, 100 infants are born. 6 of them are diagnosed with thalassemia. That means out of the newborn, 6 are out of 100, 6 are found to be thalassemic. But out of the 80 people who died, 3 had thalassemia disease. That means 3 died, 6 lived. So how many remained? 3 remained per 100. So what is the current prevalence of this thalassemia disease in this population? It's very simple, easy to calculate if you use a simple common sense of the definitions. Prevalence, what is the meaning of prevalence, doctor? Total number of the cases, new and old, divided by the total population. The total number of cases at the beginning of the study is how much? 6,000 people, 10%, that means 600 cases. Over the period of time, how many new cases added? 6 are born, 3 have died, and 3 patients added. So it became total now 603. Similarly, the new total population is how much? 100 are born, 80 have died, 20 are left. So 6020. So the current prevalence is how much? The total new plus old cases is 603 divided by the new population is 6020. So 603 divided by 6020 will give you the current prevalence of the homozygous thalassemia in this population. Is it easy? Any confusion? Come on. Did everybody understand the concept? Very simple. Old plus new cases divided by the new population will give you the current prevalence. Can you please punch everybody? Did you follow this explanation, or do you want me to once more rewind the tape? Please punch. Could you follow this question, or do you want me to revise? Yes means followed. Can I go forward, or do I need to revise? Very good. So Shiva, Manish, everyone is saying yes, we followed. So doctor, once more, this PowerPoint, these questions, these explanations, everything is made available in the online MBBS.com video library. Good to see Dr. Jagadishwari after a long time. So doctor, once more, every day I keep reminding you because I'm very shameless to remind you because I want you to get the best use of what we already have developed. Online MBBS.com video library, please don't forget. Please go to www.onlinembbs.com. Also tell your friends, please post this in your social media groups, Facebook groups. A little testimonial by you. Hey guys, this unemployed MD internal medicine, Dr. Murali Bharadwaj, he has an inborn error of metabolism to teach. Without teaching, he can't go to sleep. He can teach anything on the planet Earth. So tell your friends so that we want more number of students to join. Our students are our brand ambassadors. We don't do any special marketing. So doctor, you have this area called high yield topics. Please review this. 650 topics in 19 subjects. 30,000 hot MCQs. Every lesson has got a PowerPoint, video, quiz, everything. You have got the mock tests. Whatever we are now discussing, doctor, it all become uploaded. So we also have for final MBBS exam, third MBBS, first year MBBS. Then we also have the USMLE, step 1 coaching. All these video lectures, PowerPoints, everything become uploaded after the session is over. We remove it from the YouTube. So please tell your friends to join, and every day, whether it is a video or a book, you will be bored to read, doctor. You will get a boredom to read it. That is the reason every day I conduct this couple of hours of session, interactive, mainly with the idea of making you stimulated to go back and study, right? Now, a 43-year-old pregnant woman, new onset of vaginal bleeding. She is only 4 months pregnant, but her uterus is disproportionately larger and looking like 7 months of gestation. The beta HCG levels are significantly elevated more than 6 times. What comes to your mind? It is a gestational trophoblastic disease. Some of them will end up in choriocarcinoma. So the diagnosis, hydatiform mole, which is a cystic swelling of the chorionic villi. They usually present between 4th to 5th month of pregnancy with vaginal bleeding. The uterus grows larger than expected for the gestational age. What is a partial mole? what is a complete mole? Partial mole had some fetal tissue, but no viable fetus. Then complete mole has no fetal tissue. The hydatiform mole must be surgically removed because chorionic villi can embolize to the distant sites is what you need to remember. Now 32-year-old woman who is 34 weeks pregnant had been in the hospital for 5 days because of pyelonephritis. That's a big problem in pregnancy. The gravid uterus, especially on the right side, has a great tendency towards leading to obstruction, leading to the hydronephrosis and pyelonephritis. Intravenous lines and bleeding from the gums, petechiae. There's a thrombocytopenia. WBC count is elevated. Prolonged prothrombin time. So what is she passing through? She is passing through disseminated intravascular coagulation because of the sepsis caused by this pyelonephritis. So how do you identify that? Elevation of the dimers. Because disseminated intravascular coagulation, there's an extensive fibrinolysis throughout the body. Every time fibrin is getting broken down, there's a release of the D dimer, is what you have to remember. A 52-year-old man presents with jaundice. No abdominal pain, no Murphy's sign. That means you're not thinking of any acute cholecystitis. The treating physician is concerned that he can feel the patient's gallbladder. So, a palpable gallbladder with a jaundice in an elderly person. Not very elderly, but any person. You have to think of a malignancy like head of the pancreas cancer. So you all know there is a liver and the bile duct is coming out, and here you have the pancreas. When there's a tumor of the head of the pancreas, it will lead to obstruction. So that what will happen? The gallbladder secretions cannot pass out. That lead to gallbladder get distended. Whereas if it is cholecystitis, what will happen? Chronic cholecystitis lead to fibrosis of the wall of the gallbladder. So gallbladder is shrunken. If there is cholecystitis, gallbladder is enlarged. If there is a head of the pancreas tumor compressing the bile duct, leading to the development of an obstructive jaundice. Who said that? Carvoiser. So what is Carvoiser's sign? Jaundice, palpable, enlarged non-tender gallbladder. Because of the cancer in the head of the pancreas obstructing the gallbladder from emptying is called Carvoiser's law, is what you need to remember. Whatever. Very good. We have 43 online classmates. Today we should cross 50. And you all should promise me you will bring another 2 to 3 of your friends to this evening get together. Right? So, every day we will spend a couple of hours and then discuss, debate and discharge at least 50 clinical vignette based or image based USMLE style questions and get ourselves ready for the exam. 26-year-old man diagnosed with medullary thyroid cancer, and his blood tests show hypercalcemia, increased catecholamines. Oh, this is a good finding. This is a new finding. His father also had medullary thyroid cancer in his 20s. And yes, thank you, Dr. Abdul Majid, our CT surgeon. I will make it 100 audience in 1 week, sir. Definitely. Thank you so much. And Dr. Abdul Mazid has sent us around 400 phone numbers, screenshots of lot of the friends. So, doctor, it will be a great help if you can send the screenshots of your classmates, uh, phone numbers to our helpline 9000868 so that we can be able to reach out to your classmates and also invite them to the online mbbs.com. So, doctor, the parathyroids are removed in his father. So, what is the possible mutation? That means this is a medullary thyroid carcinoma with a genetic predisposition, familial. So, that typically occurs with the red proto-oncogene, is the one which is basically associated. So, MEN1, MEN2, MEN2 has MEN2A, MEN2B. Such a frequently asked and the favorite topic of the examiner, doctor. MEN1, remember all central organs, pituitary, parathyroid, pancreas, all the three are central. So pancreas, pituitary, and hyperparathyroidism, hypercalcemia, and Zollinger-Ellison, because in the pancreas, gastrinoma will lead to Zollinger-Ellison, and various pituitary tumor syndromes like acromegaly, Cushing's, galactoria is a presenting feature. Then MEN2 has pheochromocytoma, medullary carcinoma of thyroid, mutation of the red proto-oncogene. It can be 2A or 2B. Typically 2A means there is parathyroid also, whereas 2B means mucosal neuromas will make it 2B. So 2A has hyperparathyroidism, hypercalcemia, medullary carcinoma of thyroid, increased calcitonin, increased catecholamines. Whereas the 2B, there are mucosal, lumpy, bumpy neuromas, morphinoid habitus, medullary carcinoma, increased calcitonin and increased catecholamines will make 2B. That's what you should remember. A 62-year-old smoker presents with a lump in the upper outer quadrant of the right breast. Mammography confirms that it is a 2.5 centimeter lesion. You have done a core needle biopsy, it has shown invasive ductal carcinoma. The patient undergone lumpectomy with axillary lymph node dissection, referred for chemotherapy. Now, whenever you are giving chemotherapy, which of these need to be co-administered to this patient? Question number 12. Come on, punch your answers, doctor, everybody. Okay, Manish Krishna is betting on leucovorin. Any other answers? Ayatvani is proposing Mesna. Manish is very intelligent guy. He changed the political party. He is also now saying Mesna. Very good. So, doctor, what is the chemotherapeutic regime of breast cancer? CMF regime, it is called as. Cyclophosphamide, methotrexate, 5-fluorouracil. Or you can even give cyclophosphamide, doxorubicin, and 5-fluorouracil. So both the regimes have cyclophosphamide. It is also used in non-Hodgkin's lymphoma, ovarian cancer also. So the most important toxicity of the cyclophosphamide is hemorrhagic cystitis. And that can be prevented by the co-administration of the Mesna is what you need to remember. What is the primary target of low molecular weight heparin? How does it differ from high molecular weight? So you should know predominantly on factor 10. So you should know the coagulation cascade. Factor 2 is called prothrombin, it becomes 2A. That's the whole idea. How to make this 2 become 2A. Miss 2 into Mrs. 2. So this is a marriage. So marriage requires a priest and it requires a bridegroom. And who is that bridegroom? Factor 5. Who is the priest? Factor 10. So 2, 5, 10. These three belong to the common pathway. Now there are few from the boys' side, few from the girls' side whenever there is a wedding. So you have factor 7, who is the only invitee from the girls' side. Imagine girls' parents are both divorced. Only person who attended is girl's mother. Factor 7. Boys' side, there are a lot of people. You are having factor 12, factor 12, factor 10, factor 8, factor 9. They all constitute intrinsic pathway. Then after the 2A forms, typically the clot is formed, but that is stabilized by the factor 13. Factor 13. So factor 13 is neither the part of the intrinsic nor the part of the extrinsic pathway. It is separate. 2, 5, 10 is a common pathway. 7 is the extrinsic pathway. Everything else is intrinsic pathway. So now, how can you be able to create an anticoagulant? If you take the regular heparin, it does not go and directly act any of these coagulation factors. The heparin will make the antithrombin to become active. Antithrombin will go and inactivate factor 2A and factor 10A. So that is the reason you need to follow APTT if you are giving an unfractionated heparin. Whereas a low molecular weight heparin predominantly goes and acts on factor 10A only, not on 2A. That's the reason you don't need to monitor it by doing APTT. That's the point. 18-year-old boy presented with pneumonia. Alpha hemolytic gram-positive cocci in pairs have been found. His peripheral smear, what can you see, doctor? You can see sickle cells. So now the question, why sickle cell anemia patients are highly vulnerable to the capsulated organisms like pneumococci is the question. Because in sickle cell anemia, inside the spleen, there are a lot of microvascular infarcts. These sickle cells will go and get sequestered in the blood vessel, decrease the blood flow to the spleen, leading to microvascular infarcts. And that results in splenic dysfunction, which is the underlying cause for the development of capsulated organism infections due to splenic dysfunction. If the spleen is not there, opsonins cannot be produced. If the opsonins are not there, the capsulated organism infections will increase. That is the logic. Which laboratory test supports the diagnosis of cobalamin deficiency? So, doctor, Elevated methylmalonic aciduria is an indication of the vitamin B12 deficiency. Why? Because if you take odd chain fatty acids, very good. Pradeep Reddy adds a beautiful point. Salmonella, why it is more common in case of sickle cell disease? Because in sickle cell disease, there is an increased availability of iron, and Salmonella is an iron-loving bacteria. Very good point. So odd chain fatty acids. So normally if it is even chain fatty acid, let us say propionyl-CoA. How many carbons? 16 carbons. Every time beta oxidation of fatty acid occurs, it releases an acetyl-CoA. 16 become 14, become 12, 10, 8, 6, 4, 2. Very good. But if it is an odd chain fatty acid like something that has got 17, so then what will it finally lead to? 3 carboned CoA. That is called propionyl-CoA. So how is propionyl-CoA metabolized, doctor? Propionyl-CoA containing 3 carbons become methylmalonyl-CoA by the addition of 1 carbon dioxide. For that you require propionyl-CoA carboxylase, which is called biotin, which has biotin as coenzyme. Methylmalonyl-CoA becomes succinyl-CoA by the action of methylmalonyl-CoA mutase, which typically has vitamin B12. Vitamin B12. Succinyl-CoA typically then enters into citric acid cycle. So if the vitamin B12 is not there, methylmalonyl-CoA mutase cannot work and methylmalonyl-CoA levels will increase. That lead to methylmalonic aciduria, which is the way to detect the presence of the vitamin B12 deficiency, is what you need to remember. Concurrent use of erythromycin and cyclosporine, what will it lead to? It leads to increased cyclosporine concentration. So how does cyclosporine act, doctor? Typically cyclosporine is an immunosuppressant. Those who have renal transplant, you use cyclosporine. As the name itself says, it binds to cyclophilins. It blocks the differentiation, activation of T lymphocytes. How does it do that? It inhibits the interleukin 2 production. By doing so, it blocks the differentiation and activation of T lymphocytes. Then what is erythromycin? Erythromycin is a macrolide antibiotic which basically inhibits 50S ribosomal subunit. Now, doctor, if you give erythromycin and cyclosporin, erythromycin inhibits the cytochrome P450. But that is the place where normally the drug metabolism of cyclosporin occurs. So that is the reason whenever you combine, the cyclosporin is no more metabolized. That's the reason the cyclosporin serum concentrations will increase, is what you need to remember. A 64-year-old diabetic man with chronic renal insufficiency with a low glomerular filtration rate. He has a transitional carcinoma, started on chemotherapy. So somebody who has got a renal dysfunction, which cancer chemotherapeutic agent should be avoided? Very good question. Cisplatin. Cisplatin will lead to nephrotoxicity and acoustic nerve damage. 2 important toxicities. Before you give cisplatin, 2 things. Check the kidney damage, kidney function, and vigorously hydrate the patient. So cisplatin is avoided in the patients who have got renal dysfunction, is what you should remember. A 68-year-old man presents with high SR, with anemia, with severe back pain. You have done bone marrow biopsy. What is it showing, doctor? It is showing increased number of plasma cell precursors. If the plasma cell population is more than 30% in the bone marrow, that defines multiple myeloma. So that is the reason the diagnosis is multiple myeloma. So the off-center nucleus, the nucleus is not in the center, off-center nucleus. Clock face chromatin distribution. That is how a myeloma's plasma cell is being recognized on histology. Hydrops fetalis in thalassemia. What is it because of? It is due to excess gamma globin chains binding very weak to the oxygen. So when the alpha globin genes are missing, then the gamma globin chains will start accumulating. So that lead to formation of tetramers, which are known as hemoglobin bards. These tetramers, they bind so strongly to the oxygen that the fetal tissues no more have an availability of oxygen. If the affinity for oxygen is very high, it is not ready to deliver, then what will happen? Fetal tissues suffer hypoxia. And that lead to the development of hydrops fetalis because of HB bards, due to excess gamma chains, due to the relative absence of alpha chains. In case of severe alpha thalassemia, is what you need to remember. A 32-year-old woman presents with excessive amount of the bleeding from the gums. There's an increased partial thromboplastin time, increased bleeding time. Then what treatment is going to alleviate her symptoms? Always remember, doctor. Man, bleeding diathesis. Think of hemophilia. Woman, bleeding diathesis. It can't be X-linked. It should be autosomal recessive. That is von Willebrand disease. Woman, bleeding diathesis. Von Willebrand. Man, bleeding diathesis. Hemophilia. Simple. So, you have to give something which has got a von Willebrand factor. That would be cryoprecipitate. So, cryoprecipitate contains fibrinogen, factor 8, factor 13, von Willebrand factor in abundance. A 38-year-old woman, sudden onset of vomiting, epigastric abdominal pain radiating towards the back, elevated WBC count, thrombocytopenia, increased amylase, lipase. All these are pointing towards pancreatitis. And what is predisposing factor for pancreatitis? Quite often it is the gallstones. The gallstones are obstructing the bile duct. That's the reason the common bile duct is dilated. CBD dilatation, central bile duct, common bile duct dilatation with gallstones predisposing to pancreatitis. That's the reason. What is your diagnosis, doctor? Acute pancreatitis. A 47-year-old presents with an increasing epigastric pain, heartburn, weight loss, very important. The patient is thin and pale with diffuse tenderness in the epigastric area. Serum levels of which substance are elevated? So this is a case of Zollinger-Ellison syndrome, which is gastrinoma. That's the reason gastrin levels are typically elevated. A 5-year-old girl presented with a 12-hour history of projectile vomiting and headache. Her parents say that the patient was well until 4 months back. Then she is becoming clumsy. There's a nystagmus in all directions of gaze. If she looks to right or left, gaze evoked nystagmus. Truncal ataxia all points towards a posterior fossa tumor. So typically that would be a medulloblastoma. So how will be the histology, doctor? Small tumor cells, little cytoplasm, crescent shaped, deeply staining nuclei, arranged like pseudorosettes. So this is the typical description of the medulloblastoma. So deep staining nuclei with scant cytoplasm arranged in pseudorosettes. And medulloblastoma is highly radiosensitive. A 59-year-old man with an easy bruising, splenomegaly, fatigue. What can you see, doctor? You can say or rod. Or rod is suggestive of a myeloid cell. Which myeloid leukemia has got a significant splenomegaly? CML. So chronic myelogenous, but in this case, right now there is anemia, easy bruising. That makes it more likely to be acute myeloid leukemia with the presence of OR rods, AML. Now, doctor, 68-year-old women with 6 months history of burning epigastric pain. Hemoglobin is 8.5. Hematocrit is 24%. And mean corpuscular volume is very low, microcytic anemia. So, epigastric pain, history of burning, peptic ulceration, black colored stools, that means upper GI bleeding. So it is the iron deficiency anemia secondary to blood loss is what you need to remember. So doctor, there are 25 more questions for us to discuss. Let us take a quick 15 minutes break. Almost past 1.5 hours we had been laboring. Let us take a 15 minutes break. It will be more effective. So go to the kitchen, catch up a cup of tea. Now the time is 8:20. We will meet at 8:45. 8:45, quarter to 9 p.m. We will once more rejoin and finish the remaining 25 questions of discussion. So please once more re-log in at 8:45 p.m. just to take a short break. Thank you very much for joining, and once more rejoin for the part 2 also. Thank you.